So this question is actually for Dr. Mark. Yeah, so because I just slightly ran through a slide just now, do you have any idea how does statins affect our mitochondria?
That's a great question, and one of the slides I didn't get to, as I always try to have too many slides, and David Diamond's presentation also had some references. So statins do affect the mitochondria, and we don't know exactly all the mechanisms, but they affect the mitochondria in a negative way. I mean, some people might call them, in certain probably genetic predispositions, they might be mitochondrial poisons. So, you know, predisposition to more type 2 and poorer blood glucose control. So across the board, you know, I think all of us as patients and clinicians need to answer the question, you know, yes, there are, as we've heard, there are cardiovascular benefits in the people who have the worst situations, you know, the worst already established cardiovascular disease, you know, and, you know, really horrible lipid panels, there might be some role. But yes, I think that's the mechanism. And there are a couple articles I have in the Dropbox folder go in deeper to the mechanisms about why, you know, there might be this predisposition to diabetes on statins, but it all comes down to the mitochondria and how it's affecting the mitochondria.
I think the statins also damage the liver, which is responsible also for converting sugars to fat. So if the liver is damaged, can't make fat, so your glucose stays high.
And it might be a dose response, so pravastatin, water-soluble statin, might be less toxic to the mitochondria than a high-dose atorvastatin.
Cool. Next question.
Hi, my name is Patty Hecht. I'm here with HealthQuest. I was fascinated by the presentation on lipedema, and I'm wondering if there's any information as to the root cause of that, because as we all know, we don't really truly solve something until we know the root cause. Thank you.
We're looking for that, and there is a number of researchers that are actually looking at genetics because we are seeing presentations in families, but you also have a similar diet in a family too. So, but we are looking at that. Siobhan, you have anything to add to that?
Yeah, I'm pretty bullish on root cause investigation as well, so it's something I've been looking a lot into over the past couple of years. I have a lot of thoughts. We only have about 40 minutes here, so I don't know if that's enough time. But yeah, if you look into past presentations I've done, there might be some interesting stuff there. Karen Herbst has also been looking a lot into the connective tissue kind of connection with that as well, which I think is interesting.
Siobhan, a quick question for me. Might it be simply glycation from the sugars, sort of like vasculitis, which damages vessels, so it causes lymphadenitis, basically?
I'm not sure on that. I haven't seen it investigated or anything like that. But there does seem to be a lot of food sensitivity going on as well. So it seems to be any trigger of inflammation can kind of worsen the symptoms. So I think it's just overall body not doing great.
And I will add to that that there has been studies on mice on with induced lymphedema, and given a high fructose diet, and the lymphatics become hugely inflamed. So they have a reduced transport capacity and result in swelling. So I think there is definitely something going on there.
All right. We have one question here. Marty, what are your thoughts on the growing concerns about oxalates? What nutrients would be most challenging to optimize on a low oxalate diet?
Yeah, I mean, definitely don't double down on the almond flour and the like that a lot of people tended to do when they started a keto diet. Not many people overdo spinach, and there's definitely a tolerance level you'll find if you're overeating the spinach. Your gut will go, no, too much, back off. But if you have a varied diet that contains a range of minerals, particularly calcium, people tend to clear the oxalates well, but there's definitely a role for a low oxalate diet for people who have definite symptoms and diagnosed issues. So yeah, and a low oxalate diet can be a lower nutrient density, less colorful diet.
My urologist never told me that my kidney stones were from spinach. So I suffered for years until I found the low-carb keto world.
Yeah, you definitely don't want to be doing smoothies of a ton of spinach all by itself.
All right, next question.
Yes, my question is about zone 2 exercise. And I'm not going to be hooked up to cables in a lab, and no one is going to tell me what my acetate level is. Or if I'm outside for a while and I want to go into the zone 2, zone 1, zone 2, how do I know where I am?
Yeah, that's a great question. Didn't get into the whole practical side of that, but a couple ways that you can tell if you're in the right space. So we breathe in oxygen and we breathe out carbon dioxide. So you could, if you can talk like I am right now and maybe a little upper end, like, okay, you know I'm exercising, but I can carry on a pretty good conversation, you are in zone 2. Right? You're not producing too much carbon dioxide. Now, as soon as you go into the more glucose burning, you know, my sentences might become shorter. So that's a good way just on your own intuition. We call it like a heads-up display, like you have in your car. You have to be able to sense and feel things, and then you could look at, you know, maybe you would do 180 minus your age is another way some people will estimate that for your heart rate. You know, but the things you can just intuit by how you feel. The other is nasal breathing. So if you can breathe in and out through your nose, you know, yeah, and then a little faster you can't, you're going to have to use your mouth a bit. So if you can breathe in and out through your nose, you're probably at the top end of zone 2, right? When you're about not able to do that. And that's a very calming place to be. You're more in that parasympathetic side, you know, rest, digest, calm your heart rate, versus the adrenaline side. We do high school camps for kids, high school runners, and none of them understand how to recover or go slow. So we take a piece of tape and we have them like run around the park with a piece of tape over their mouth. The hardest thing for them to do is just not talk, because they like to talk. But it's amazing how slow they go because they don't know how to recover. And if you don't recover, you're wasting your time, right? They all focus on how hard they can run every day, and then they're toast by September when their bigger meets are like in October. But there are a couple simple ways just to sense it on your own. Use a heart rate monitor. You could also use, it's called the Kervonen method, which is called heart rate reserve. From your top peak heart rate to your resting heart rate, 70% of that. You know, but you don't really need those technical tools once you intuit it a bit.
Yep. So if I can ask one more question about that, how often, for how long is that going to be effective or productive?
Yeah, so optimum, you want to, I mean, all of us are limited in time, right? But really, you need to get out there to maximize that effect on your mitochondria, really, you know, an hour to 90 minutes. But most of our patients, that's the well athlete. The Med-S patient, who's a totally different species, right? We want them just to get up and walk and move, even if they can do 3 10-minute, you know, just get them off the couch. You know, we're not like close to optimizing those folks yet. We're just trying to, I mean, return to factory settings is really what we want these people to do with their health and mitochondria. Those people are 20 years into you know, dysfunction. It's going to take them a long time to back out of the room. But for the otherwise well, you know, no kidding, 60 to 90 minutes 4 times a week, we should be able to find that time, or else, you know, we're going to pay the price later when the check comes due for our own health.
Thank you.
Thank you. Next question.
Well, that was a very well-timed question. My name is Casey Ruff. I host Balanced Body. This question and observation is for Mark. So you showed the video of doing the VO2 test, excuse me. I don't know if you knew this, but that was my career. I was running VO2 tests. I did that starting in 2007, stopped in 2020 when it wasn't a great idea to stand next to a treadmill with respirated air concentrated through a tube right next to you. But in that time, we were measuring peak optimal fat burning ranges. And yes, everything that you're saying, I can say I observed that the 180 minus your age almost always correlated with where we measured an aerobic base or a peak fat burn. And almost always the RPE scale, the scale from 1 to 10 of how difficult a current intensity is, almost always peak fat burning happens about a 5. So if 1 is sitting down watching Drive to Survive on Netflix, 10 is running away from a tiger as hard as you can, if you can find yourself at a 5, that is generally where you're going to get the very best fat burning results, at least from what I observed. So I hope that's helpful. But then the question is, for somebody who's training for a specific event, why might it be important for them to consider the timing of when they start doing more of that training versus just general population where anybody can benefit pretty much year round?
Yeah, that's a great question. Most people in the room here and our patients aren't training for an event, so we just want them fit and well. But if you are, it's all periodization of training. So as you're getting closer to the event, you're going to be adding more high intensity. A lot of this is just neuromuscular, and whatever your sport is, if it's running, you got to run fast in your training to be able to run fast. And some of it is lactate tolerance, right? So if you're a 1,500 meter runner, a mile runner on the track, that last lap is you're bringing your lactate up to 15 plus, and if you've never trained that, you're not going to be able to. You're not going to tolerate that. You're just going to blow up. So, but if you don't have that type 1 fiber system built, you won't even make it to the 4th lap of a 4-lap race. You'll be already too acidotic, and when people start tightening the screws in the race, you're dropped off the back. And Peter Snell, who won 2 gold medals in 1964, won a gold medal in 1960, and he won the gold medal in the 1,500 meter race by from that microphone to that microphone, and that's like a blowout. It's like a 40-point win in an NBA game, and because he was tolerating the lactate and not building up the lactate so well in the first 3 laps, and then when it came time, he just ran away from everybody.
Wow. Yeah, that's amazing.
And it depends, it's specificity. So if you're going to be a marathoner, where you don't need to sprint 60 seconds for a lap, you don't really need to do that. So it's specificity toward the event. That's like Tour de France training. They have to do a lot of high intensity glycolytic work to do the climbs, but they spend a lot of time in the off season and during the season they go for 4 to 6 hour rides, just talking. And then as the time gets closer to their race season, then they'll start to add in the specific work. But they can only sustain that for so long. So when people do a lot of high intensity, you've got about a 6 to 8 week period where you can tolerate the high intensity before you kind of fall off the cliff. So the timing of that is critical.
Yeah, well
do
said.
it too early and you'll flame out before your event.
Well said. One of the other complaints I would always get is people would ask, well, do I have to keep my heart rate at aerobic base for every zone 2 workout? And it's like, yes, but you're going to get faster. Like you can come back and do this in 3 months. You're going to be running maybe a mile an hour faster. Your performance is going to improve at the same heart rate. So anyway.
Thank you very much. Appreciate that. Next question.
Hi, I'm Andrew from Malaysia. Yes, yeah. So my partner in crime is Jasmine. So we own Malaysia's largest reversing diabetes center, and we have 1,000 patients under our care. All right, my question is for. Thank you. Yes. Oh, by the way, we won the furthest. We are the furthest participants here. By the way, yeah. Okay. Anyway, my question is actually for Dr. Amy. Yeah. Thank you so much for presenting on the fatty livers in kids. Yeah, but I would like to ask you a little bit about fatty liver in adults. Is that okay? Right, because I can see most of us here are adults, right? Although we might be young at heart. Yeah. So, does low carb reverses fatty liver in adults? First question. Second question, if it does, how long it takes? Third question, that will be the third question. If a low carb can't help patients in fatty liver, what else can we do? Yeah.
Okay, we'll see. First question, does it work in adults? Right, okay. So I think one of the hallmark studies that I always reference when I'm writing these proposals is Jeff Browning's work. He did a 2-week ketogenic diet intervention in adults with fatty liver disease. And I think in just 2 weeks, he saw like a 50% decrease in their liver fat. And this was matched to a energy restricted diet. The 2 diets were matched for energy. They were reduced calorie. The ketogenic diet group, the 2 groups lost the exact same amount of weight, but the ketogenic diet group had the metabolic advantage in terms of losing far more liver fat than the other group. So that's like, there aren't a lot of studies in adults that are well controlled and well done. So I think there's a big gap in the literature in general when it comes to carbohydrate restriction in any population with fatty liver. So does that answer your question, how long it takes? 2 weeks, you can see a pretty significant decrease in liver fat with a ketogenic diet. And the last question, what if that doesn't work? And I don't know if I have a good answer for that one.
All right, thank you.
It works.
Yeah, it works, it always works.
I'll just add on to that. The study I was referencing in terms of the increased folate production in the gut was actually originally looking at the impact of low carb on fatty liver. I bet Amber knows the title. And then Verda also reported good results in terms of improvements in fatty liver, which both were in adults. So it's not as tightly controlled and potentially as awesome as her study, but still there is some support for that.
Thank you. Next question.
I don't know if I remember the title, but I'm pretty sure the author is Martin Oglu. My question is also for Amy. You were looking at correlations, the characteristics of what got the best results, and you said that the higher the fat intake, the better the results were for reducing liver fat. And I'm wondering if you have any hypotheses or speculations that you would be willing to share with us about that, because for a lot of people that might be counterintuitive.
Sure. Yeah, so in those multiple linear regression models, I was trying to tease apart sort of like, so obviously in that group, they lost body fat, right? So I wanted to see like, was there a linear relationship sort of independent of overall caloric intake and independent of change in body fat on that follow-up hepatic lipid. So the association with fat, right? So there was pretty strong with percent energy from total fat. That held up when we broke it down. The higher intake of saturated fat also resulted in, less liver fat at follow-up, along with the MUFAs. But, it's difficult to tease apart, right? Like, if they were eating higher fat, that also meant they were eating lower carbohydrate. And that, if you're driving down your insulin, you're enabling your liver to start oxidizing fat at higher levels, and that alone is what will deplete liver fat rapidly. So, I mean, at the end of the day, I think it goes back to bringing down the insulin and enabling fat oxidation at the level of the liver.
Right. The saturated fat part is interesting, which it's also shown to be protective of fatty liver from alcohol-related fatty liver. So that's also interesting. Thank you very much.
Yeah.
Amy, question for you. When you eat sugars, aren't you making fat in the liver? But when you eat fat, it goes to the lymphatics. So you're essentially just reducing the amount of fat you're making in the liver?
That's right. Yeah. So the de novo lipogenesis, and that one slide, I probably didn't spend enough time on it, but the DNL is in fact suppressing fat oxidation, right? And there are a number of factors that are affecting DNL, but if you're not engaging in that high level of DNL, then fat oxidation levels will increase, right? So you're going to be oxidizing both the endogenous free fatty acids, you're going to be oxidizing the fat you're eating, you're going to be mobilizing the fat from the liver and burning it. So it's, a lot is contingent on whether, the level of de novo lipogenesis that your liver is engaged in.
Great, thank you. Virtual question. Women with lipidemia, do you have any experience with women checking their ketones?
Sorry, what was that?
I am a woman with lipedema, and I do have a lot of experience checking my ketones. I'm not sure if there was any specificity beyond that. When I was losing weight just on stock standard keto, high fat, moderate protein, my ketones were up around 5, and I was rapidly losing weight at the time. Now on high fat carnivore, they're more around 2 to 3 millimoles, but I've seen them all over the place. It usually is just reflecting what I'm eating.
Suggest measuring it?
Maybe, if you find it interesting. I find it helpful just because it reflects my fat intake and I do better with higher fat, but if that's not an important part for you, it might not be necessary.
Thank you. Next question.
Yeah, this is actually for Leslyn or Siobhan. Obviously, I'm a bit dumbfounded because I actually didn't see a lot of those case report pictures. I mean, it's very transformative. What do you feel would most advance research into keto for lipedema?
So as we saw in Leslyn's portion, there's a lot of research being done into keto for lipedema. But I think one thing that's actually unfortunately lacking at the moment is there's not an official case definition. So that means when we're doing studies, there's no standardized way of saying this person definitely qualifies as having lipedema for our study, and that's also important for putting together a control group as well. But another thing I'll say in terms of that is to keep an eye out from the lipedema project in the next couple of months.
Thank you.
Next question.
Hi, my name is Darius. I'm an ER nurse from Sacramento, and I'm also with the Health Quest team. My question is for Dr. Mark. I like to run these Spartan races, and they're like, for people who aren't familiar with them, they're like an endurance event with obstacles. So a lot of glycolytic stuff as well as running. I'm scheduled to compete in their like world championship race in November in Greece. And so I've been training this year, and thank you. I'm training this year, and endurance is where I suffer. I can do all the obstacles, I can breeze through those, but as soon as I start running, all the runners just go right on by me. So I've been working on that, and one of the things that I got done is I got a DEXA scan, I got a resting metabolic rate and VO2 max done back in December, and my respiratory exchange ratio was right at like 50-50 carbs and fat. A couple questions. One is, do you know the implications of like an endurance athlete and how well that the respiratory exchange ratio, what implication that has for how good your endurance is? Second question would be for zone 2 training, which I've been focusing on a lot more lately. Is there any benefit to, at the end, say, of a solid hour of zone 2 running, is there a benefit to doing like a quick, couple of intervals, like fast sprints at the end of that, or is it more detrimental to that?
Yeah, Darius, that's a couple great questions. So events like Spartan races, they're like if it's like a beast, it's like a 2-hour, 13-mile-ish, 9-mile. So you have to be able to do the high-intensity stuff where you're going to be climbing a wall, burpee penalties, whatever it is. So you're producing pretty high quantities of lactate. But the bigger your type 1 system is, you can buffer that, right? So you'll be able to recover. So it's just like track racing, doing longer track races. It's who can recover from the surge. Someone decides to, attack in a bike race, right? You're in that zone 4, and then they settle down. Like, who can get back into that kind of gear 1 the best, because then they're going to be able to use fat for fuel longer, and they're going to be in a better place metabolically for the duration. So like in any sport, you train for your weakness. So if you're more adapt to power, speed, and strength, but you know that in the event that you're training for, oh gosh, I need a little more endurance, then that's where you have to put a little more time and put the money into that. But doing like sprints at the end of a workout, so Arthur Lydiard called these alactic sprints, because they were like 40 to 60 meters, and you wouldn't really produce high lactate levels. So high lactate levels chronically will sabotage your aerobic development. So people doing that stuff, like hard interval training day in, day out, they'll kind of shut down their aerobic system. But I do every day at the end of my runs, I go out to a field and I sprint, just short sprints, because that helps your neuromuscular coordination, right? Because you just have to have that, that relaxed movement, and you can do that stuff year round, and while you're doing base endurance training, drills and sprints. So that stuff's all perfect, and that's kind of the skill part of your sport. Just like if you're doing obstacles, there's a huge skill component to how you can do the obstacles super efficient without going into zone 5 every time. But I hope that makes sense. And it takes months and months and months to build, years and years really. So like the best CrossFit Games athletes, the best Spartan racers, these folks have years of some level of endurance. They came from a different sport background, a lot of them, some type of endurance sport. And then, these Spartan races are fun, right? This is a new sport, new entertainment, new challenge for them.
Thank you. About the respiratory exchange ratio.
Yeah, the respiratory exchange ratio. So all that tells you is, are you burning more fat or carbohydrates? So the type 2 diabetic patients on insulin or hyperinsulinemic, they're 1.0 sleeping, right? So they're not burning any fat at all. We're giving them Lantus at night. they're burning no fat all day. Now, the mitochondrially well, like the homo badass people, these people are burning, their RER is 0.7, running, Eliud Kipchoge running a 5-minute mile. So the healthier the mitochondria are, the more you can be in that lower RER at higher efforts. And that's your breathing. You can tell that from your breathing, because you're breathing fast, you're making more carbon dioxide that you must expel. And all of us, if we're out on a ride, a group ride or a group run with friends, someone decides to speed up and he's chatty catty, and then the rest of us are breathing really heavy. So that person's still in zone 2. They're more fit than the rest of us who are getting dropped.
Thank you.
All right, Marty, virtual. Does satiety only come from protein?
Protein is one of the nutrients, and many others contribute as well. The studies with GLP-1 tend to indicate that our overall nutrient density stimulates GLP-1 endogenously. Satiety, as I mentioned, is one of the nutrients, definitely the dominant nutrient in the satiety equation, but as I mentioned, potassium, sodium, calcium, even cholesterol, surprisingly, tends to stimulate greater satiety because we're satisfying our cravings for the nutrients we need.
Okay, thank you.
Thank you.
Cool. Next.
My name is Andre. Come from Zurich, Switzerland. I would like to talk about fatty liver disease in Switzerland.
Could you talk to the mic, please?
The fatty liver disease in Switzerland. This question or encouragement is for Amy. As a radiologist, I've examined the fat content of kids in Switzerland. I found that 80% of the kids have more than 5% fat in the liver. But I've also found that a certain subset of kids have no fat in the liver, and these are all kids that have epilepsy and are on a ketogenic diet. So it is possible with a good diet, if you reduce the carbs of almost 0, there is no more fat in the liver. And I think I would encourage you to be able to reverse fatty liver disease in your population of kids. Would that be possible for you to do in the new studies?
Would it be possible for us to do a ketogenic diet? Is that what you're asking?
Yes, ketogenic diet.
Yeah, so I get that question a lot. Because obviously we're recommending, the intention is not to be in ketosis with our diet. It is, we are recommending, and even with our larger study that we're now doing, around 90 grams per day. So like 60 to 90 grams, depending on their energy requirements. But yeah, in an ideal world, we would put them all on a ketogenic diet, and that would fix their fatty liver, because I'm convinced it would. So I get the comment a lot, like, why don't you just go lower on the carbs? But I do think, in a research study, you sort of are playing this game where it's like, if you're too restrictive, not that I think a ketogenic diet is too restrictive, but you will have participants that will struggle to adhere to it and could increase the likelihood that they'll drop out of the study. I don't know. So with the pilot data, we did get good results with the 60 to 90 gram level. So that's what we proposed in the larger grant as well. But like you're saying, I do think I think the ketogenic diet would be more effective at depleting liver fat. Yes.
Keto cures. Next question.
Hi, Julie, nurse practitioner. This is for Amy, but anyone else can also chime in. I'm wondering the implications of such a high fructose corn syrup nation that we live in, and the implications on the liver, especially these kids who drink, and adults, but you're dealing with the children, the implications on their liver disease.
So, I mean, we always ask our kids at baseline, what their usual dietary intake is, and most of the time they are consuming sugar-sweetened beverages all day long. In the pilot study that I presented, both diets that we designed were intended to be low in added sugar and low in processed foods. So we wanted 2 diets that were high quality to sort of take that confounding factor out of it, to really determine if it truly was just like a macronutrient composition thing, or if it was, it's confounder if one of the diets is highly processed and the other isn't, right? So, the removal of sugar-sweetened beverages alone can probably prevent further progression of fatty liver, but if we're talking reversal, I'm convinced it has to be some sort of carbohydrate restricted diet. But yeah, I think, you know, a lot of these kids are drinking sugar sweetened beverages that are high in, you know, high fructose corn syrup all day long, and that is a big contributor to deposition of lipid in the liver.
So you did not buy them on their grocery list, you didn't buy them soda, right?
Right, no, we did not. No sugar, or no soda, yeah.
There's a really good study by Robert Lustig on, I believe he did 10 days of just getting, you know, not a low-carb diet, right? These kids are eating bread and pizza, just getting rid of the high fructose corn syrup, the juices and the drinks, in 10 days showed reversal of the liver metabolic. We're doing a pediatric study now, and they're seeing very similar things to Amy. You know, we had a child, we just shared before the talk, we had a child in 4 months take their transaminases from the 400 level back to near normal. And the child had only lost about 10 pounds. It was a 300-pound 16-year-old. So the child was kind of frustrated, but I think there's something about like that kid's liver was so packed. But once we explained that to the child, they were actually much more like feeling good about, because it is hard. It is hard for a child. They go to school, they are exposed to school lunch, they eat at friends, you know, at all their sports things, people are bringing snacks. It is really hard to keep these children on this way of eating in the world as it exists now.
Next question.
Hi, Laura Goldberg from Los Angeles. This question is for Dr. Kendall. I had a question about considering the satiety effect of potassium and sodium. I was thinking about using like electrolytes as sort of a weight loss tool. What do you think about doing that? And then is there an upper limit? Like if somebody wants to be drinking water, you know, infused with sodium and potassium 5 times a day, is there a problem with that to stave off the hunger?
I'm not. Definitely supplementing with electrolytes can be helpful, especially if you're lower in electrolytes. Not convinced on satiety benefit of supplements alone, and definitely it's potassium tends to be the dominant one because most people are getting plenty of sodium. Sodium, we see an upper limit target of about 4 grams per 2,000 calories, unless you're really active and maybe a little bit more. Potassium is 6 grams per 2,000 calories. Ideally, for most people, you want to see a potassium-sodium ratio of 2 to 1 for most sedentary people. If you're very active, maybe 1 to 1. But if you can get it from food, get it from food because you get the fiber and every other nutrient that is quantified as essential and every other non-essential nutrient that may be beneficial from those whole foods that contain those nutrients naturally. Thank you.
Next question.
Hi, my name is Susan Maltz, and I'm from Atlanta, Georgia, and I also wanted to talk to Marty about this whole thing with...
Talk a little closer to the mic.
Okay, I'm sorry. I'm Susan Maltz from Atlanta, Georgia, and I also wanted to talk to Marty about the satiety index because I'm very curious about it, and I'm trying to nail down my understanding. It showed like lean protein as being the most satiating thing, and it talks about cholesterol helps. When you talk about cholesterol, are you talking about fat? Because I know for me, I'm like Mick Jagger. If I have a lean piece of protein, I'm not satisfied. I can't get no satisfaction. So, like, I need to have the fat, I guess is my point. And when you're talking about the cholesterol, are you talking about fat?
Yeah, definitely. So to cover on the fat cholesterol balance, a higher percentage of fat tends to align with eating more calories, but foods that contain more cholesterol naturally, eggs, liver, etc., tend to be more satiating. But as I mentioned, you don't want to jump from 0 to hero. Everybody wants overnight results. So if you're currently doing 20% protein, moving up to 25, 30% protein will be more satiating per calorie. Mm-hmm. But if you jump to 60% protein, your body will be going, I can't release enough stored energy that quick. I need some energy. And that's why you'll be craving fat and maybe even carbs at that point. So you want to target the most satiety per calorie, but you don't want to jump off a cliff and go from 10 to 60% protein because you will be hungry for energy at that point. So yeah, and don't be afraid of cholesterol-containing foods. It just seems to be the last bastion of processed junk food that the food industry is holding out, even though it's been cleared from the dietary guidelines.
Fair enough. Okay, thank you.
Thank you.
All right, a virtual question. Siobhan, let's see. Slides showing crossover between EDS and lipedema symptoms. Are these two conditions related, or is it more that one can be confused for the other? Thank you.
So it was asking about lymphedema and lipedema?
EDS and lipedema.
Oh, Ehlers-Danlos. So that is Ehlers-Danlos syndrome, or EDS, is a connective tissue disorder. And there's a large majority, well, I would say it's about 40% in some papers, of women with lipedema also have EDS. They're two separate conditions. So one of the things that we look at when we're trying to identify someone with lipedema is how flexible is she? And quite often they are very flexible, but not everybody with lipedema is.
Yeah, so it has been speculated by some researchers, including myself if I count, that connective tissue disorders and lipedema may relate, or connective tissue problems may be causative in lipedema, but it still remains to be studied. Like I said during the presentation, there's still a lot to learn. So I'm hoping over the future years we do clarify that, if it is causative or not, but there does seem to be a correlation there.
And they're likely all related to inflammation because of a high-carb sugar diet. Simple. Next question.
Hi, my name is Greg. Oh, here we go. My name is Greg with the Natural Life Foundation. We're in Boulder. And my question was, what do you think about the difference between raw protein and raw fats from animal foods, digestive leukocytosis, and how the body's recognizing them in their raw form as opposed to their cooked form with electron charges and stuff? Because in my experience, it seems like cooked foods have a reaction that raw foods don't, and I'm wondering if anybody's looked at it and what do they think about the body's ability to see and recognize it and absorb it easy, and then when things get altered by heat because they're denatured and damaged and the electron charges are different with the enzymes. Has anybody looked into that? What do they think? Or if you haven't, give me your theories. I'd love to hear, because I have almost 40 years experience doing majority raw, and it's completely different than cooked. And I dealt with lots of cats and humans and children, and it's literally night and day. So I'm curious. So basic thing is the difference between cooked and raw animal foods and how the body sees them, breaks them down, etc. And I don't know who's best there. I know Kiltz knows a lot.
I've only got a very brief comment that as you cook things, you leach out the vitamins, particularly the minerals hang around, and things become more less satiating, but that's my only comment. And for the electron transport chain aspect, I'll hand to Mark.
Yeah, the recognition of the body, you know, like digestive leukocytosis and things like that, where you don't get it with raw, but you get it with cooked.
I wish Bill Schindler was still here. I think he had to catch a plane, because actually Bill Schindler and the work of Weston Price, you know, did a lot of that work with traditional diets, and there was some magic about the fermented products, or they weren't products, but the fermented foods. But you know, it's a pretty thick read, and I think it's out at the Price Potager booth. There is the nutrition and physical degeneration, but certainly I don't think anyone in my world of Western medicine is getting funded for trials comparing, you know, raw products to homogenized and pasteurized milk, because the Western medical profession has considered raw products to be, you know, poisonous and full of nasty things. So no, that would never pass.
Sure.
You know, you'll probably have some side consumer research that might just answer some basic questions, but I doubt anyone's getting that deep into, you know more about this than probably 99% just by how you framed the question.
Gotcha.
But Bill Schindler might, you know, maybe send him a message over WUVA.
Oh, we met Bill. I look forward to
Yeah, because he has a
asking him
whole
that.
kitchen, and he's doing a lot of
The modern
fermented
Stone Age
products
kitchen.
and
It's pretty cool.
unpasteurized products and
Yeah.
getting it all local. And he knows the science and the evolutionary, you know, anthropology and biology of all that stuff at a level, you know, he wrote a book on it, so he's your guy.
Okay, nobody else up there has an idea? Because I am curious.
I don't have an answer to your question, but I just wanted to say your question made me really hungry. I actually have a question for you, Mark. So something that we sometimes see in lipedema is actually this lactic acid-like burn in lipedemic areas. So that could be the arms or the legs or both from very minor repetitive movement. So I'm just wondering if you have any thoughts in terms of overall health of the fat tissue having an impact or potentially lymphatics as well.
Yeah, so I mean, I think it'd be safe to say, you know, when you look at the type of intramuscular fat that someone with lipedema has, you know, as Dr. Ali's slide shows, this is dysfunctional fat. This is inflammatory fat, whereas the intramuscular fat of a Tour de France bike rider is readily utilizable, accessible, makes tons of ATP and energy. So all of these ROS, reactive oxidative species, ceramides, acidity. So acidic muscular environments just produce, you know, this discomfort, this cramping. You know, that could be something with the statins. You know, it's this cramping. It could be a local acidic environment. But until those intramuscular fats, because I'm sure there's a lot of intramuscular fat there that's really dysfunctional, that fat is not going to be able to oxidize well in the mitochondria, and it's going to be a hard reset looking at those pictures. And it was amazing results that the two of you have gotten just seeing, you know, that can happen, because I'm sure those people that had lost a lot of that lipedema, I mean, is their response like, I can walk better now with less pain? I mean, like across the board, do they just, they can go upstairs?
Yeah,
like what's
they're talking about within, the shortest I heard was 6 days, but usually within 2 weeks, dramatic reduction in pain, if not complete resolution, before any weight's lost.
Yeah, so something that pain is, you know, the acidity, I mean, we don't know. Pain is your brain telling you stop doing that. So something locally is sending a message. The brain is this, you know, captain of the ship always about when we stop and modify things. No, it's great work that you're seeing that. Walk their way out of it and get rid of the carbohydrates at the same time.
Yeah, just a quick additional comment. I've experienced it myself, but as long as I keep on a diet that does really well for me, so the high-fat carnivore, it actually stops. So it does seem to be reflecting health of the tissue and then health overall, which is really interesting. So thank you.
Next question.
Yes, I'm Guy Cumby from Fort Worth. And a question for you, Dr. Amy. Because of your experience in your job, you're a researcher, pretty clear. This study that you have planned, you said 6 months long dietary study with how many families?
In the fatty liver study, we're going to recruit 80 families.
80 families?
Mm-hmm.
So the big question, can you describe your managerial experience there to maintain compliance on dietary stuff with that many people for that long?
Yeah, sure. So we use quite a few sort of techniques, I guess you could say, to keep our participants engaged in the study. So for this study, the first 3 months, we are delivering all the groceries to the family for all their food. You know, that ends up being, you know, close to $600, $1,000 worth of groceries a week. So it's a big motivator for families to stay in the study. We do some blood draws to look at some sort of like biochemical markers to see if they're, you know, following low carbohydrate or, you know, the low fat diet, if they're sticking to it. We do, we give them digital scales. Again, this is supposed to be a weight maintaining study. So we just want to look at the effects of the macronutrients in the absence of weight loss. So we have them digitally weigh every week, and that information goes to our study dietitians. We keep constant contact with the families. They meet with our dietitians on a weekly basis. So, you know, in the past, we've had pretty good success at, you know, using these types of techniques to keep people engaged in the study and staying in it for the duration. Does that answer your question? Okay.
1 minute, we have one quick question. Who's got it? Got to go.
Okay, 1 minute. Dr. Mark, Diane from Florida. Lactate tolerance. When it comes to tolerating lactate, especially the elite athletes, the more elite, the more tolerance, is it just a clearance issue, or are they actually using it for energy? How does that work?
Yeah, I mean, we don't exactly know of, large populations, but a lot of N-of-1 studies out there. Yes, so they do the high-intensity stuff closer to their events. And yes, they can use that lactate. It's a flux. The glycogen creates lactate. So they're exercising so hard, fat burning is shut down, they produce lactate. These folks have a lot of muscle mass. They're producing a lot of lactate. But they probably train their brain in some way to tolerate that. And so they can make a lot because they're transporting a lot. They have a lot of type 2 fibers which make the lactate. So they have a pretty robust fast twitch system. So Darius, you just saw, he's a strong athlete. He can probably create a lot of lactate because he has a very, powerful system. So yeah, they train that very close to their events, and that's why they do like super high intensity to be able to tolerate. That's that anaerobic threshold. So how much can they tolerate before, in the track days we used to call it rigor mortis, right? Like before, like your body, everything just shuts down, your environment gets so acidic. But there's probably something to the brain there too that says, look, I'm just done. And the brain, activates motor units, 1-to-1. So the brain is shutting off motor units because it doesn't like what's going on.
Thank you.
But people go do the lactate testing, and they can get rowers, they can get levels up to like 15 to 20 millimole. None of us would be able to tolerate anything close to that because we're just mortals.
So a little bit more than just using. I mean, it's actually a higher level that they're tolerating before they're even using it. That's interesting. Thank you.
They train themselves to do that, and plus they're all type A, and that's called like the see God type of. You're only supposed to see God every now and then. No, serious. That's what they say. That you don't want to see God, twice a week in your workouts. You'll be frying yourself. I'm sure Peter Bruckner back there would be another wonderful person. He works with all these folks who try to see God too often.
They like the pain.
It comes home to roost. Yeah, Peter, any thoughts? You can give him the mic. You won't have a 30-year career if you try to see God like twice a week.
Thank you.
All right, that's it, my folks. Thank you, everyone. Wasn't this wonderful?